When you embrace innovation boundaries, you don't just imagine the future, you shape it. Karstadt, shaping our future. Imagine the future.
Good evening, ladies and gentlemen, esteemed doctors. It gives me great pleasure to welcome you all to today's e-masterclass webinar titled The Basics of Endoscopic Sinus Surgery. This is Tariq Najjar. I'm the marketing manager for ENT in the Middle East and Africa. And I'm honored to introduce today Dr. Tiruchi Narayanan Janakiram, the ENT head and neck and skull base expert. So Dr. Janakiram had his graduate and postgraduate degree from Madras Medical College, and he then completed many fellowships with renowned professors across the world, learning the intricacies of ENT and skull-based surgeries. Dr. Janakiram founded the Royal Pearl Group of Hospitals and is currently the managing director and chief consultant of this hospital chain in Tiruchirappalli, Tamil Nadu, India. He is highly committed to medical education and definitely has played a major role to put Indian medical education on the global outline. He has conducted maybe more than 1,000 free medical camps and tutored in several cadaveric courses. He has also authored several influential books and articles and serves as an operating faculty in numerous countries, earning himself accolades and many other acknowledgements on the way. For today's webinar, I'm also happy to introduce Dr. Saeed Al-Habash, who will be joining us and joining Dr. Janakiram in this webinar. Dr. Al-Habash graduated from Damascus University and received the Arab and European Board of Medical Specializations. He's also an expert in the field of skull-based surgery and has many publications in this field. So Dr. Al-Habash currently works in UAE in Medcare in parallel with, of course, Dr. Janakiram, and he will be sharing with us an interesting insight about the critical jump from FES to endoscopic skull-based surgery and what would that mean practically. So we would like to start with Dr. Saeed Al-Habash, and without further ado, and Dr. Habash, the floor is yours. Thank you.
Thank you so much, Mr. Tariq. Thank you so much for your introduction. And it's my pleasure all the time to be with my boss, Prof. Dr. Janakiram. We are all the time together. We're doing a lot of skull bases together in UAE, Dubai, and Sharjah. So it's my pleasure to be with him in the same time, at the same time. So just I will talk maybe 5 to 10 minutes about what is the difference between endoscopic sinus and skull-based surgery, how you can jump from this level to this level, how you start your skull-based unit with all the points in this one in skull-based, because skull-based is completely different category, completely different pathway. If you are very good like sinus surgeon, this doesn't mean that you can be a skull-based surgeon, because skull-based surgery needs specific skill and also very alert mentality. It's completely different. So just we'll talk something about skull-based, how to make a strategy for starting skull-based in our sector, especially in the private sector. So skull-based surgery, as you know, it's a subspecialty of a neurosurgery. You can say it's like the boundary between the ENT and neurosurgery and even the maxillofacial surgery. Usually, you cannot reach this level directly. You should either be in ENT or neuro or maybe maxillofacial. And then after taking the first degree, you should go to a specific fellowship or training, not necessarily fellowship, training for the cases of skull base. It needs a skull base team. Alone, one person, whatever he has skill, he cannot go to
Dr.
the
Said, sorry
Yes.
for the interruption. Can you please make sure to share the screen because we're not able to view the presentation.
Sorry, very sorry.
Yeah.
Share screen. Very sorry, very sorry. Okay, it's fine now.
Yeah, perfect. Now it's perfect. Thank you.
I'm very sorry. Okay, very sorry. Just as I told you, skull-based surgery is like a field where there is an ENT and a neurosurgery are all the time together. They are working in the same time, in the same field, and as a team, as a friends, nothing else. And you know that it needs complete skull-based team. It needs volume of access of cases. This is very important. If you want to do one case of skull-based every like 1 month or every 2 months case of small CSF leak, this doesn't work. If you don't have very good flow of skull-based surgery, you cannot go to this level. Safety is very important in these surgeries because for example, for pituitary, you should prepare yourself by complete team, ICU, very good endocrinology, very good skull-based surgeon, very good neurosurgeon. In case you need maybe shunt, you can prepare yourself anytime to make the shunt, prepare, manage all the kinds of electrolyte disturbance in the same time. So you'll find a lot of obstacles. It's not easy. When you started our center in Dubai, for skull-based surgery, it took for us at least 6 months preparation for the equipment, for everything, prepare the mentality of the people in our hospital that will deal with this level of surgery. This is not easy job at all. And as I told you, like ENT, skull-based team needs ENT and neurosurgeon, and you, of course, like surgeries should be either lateral skull-based or ventral skull-based. Everything in this the field of endoscopy or microscopy should be available in the field. Maybe, for example, the carotid Doppler is very important. The navigation is important. The high-speed drill. All of this is very important to do, and sometimes you will use this machine, these instruments one time, maybe for in 3-4 months. But this is very important because it will solve the problem in your case. A skull-based team again is complete team, and it needs dedicated surgical instruments. Intraoperative carotid Doppler, navigation, microdebridal, drill, microscope, and a very advanced camera system. Again, neurosurgery and neuro-oncology, endocrinology, plastic surgery, ICU, pedia, and very good pathologists. All the time, you should speak with everyone. If you cannot work alone. You should all the time speak with everyone of those people to know what is the problem and how can you solve it. Pathology is also very important. We are finding covering all kinds of pathologies, starting from the neoplastic, trauma, vascular, infection, especially infection. Nowadays, you know that there are a lot of cases of osteitis and a lot of cases of malignant otitis externa. Previously, we are trying to treat them by antibiotic all the time, but now it's different state, different level, and if the patient is not responding, we can go directly to do any kind of surgery, like either infratemporal fossa approach for the lateral skull base, or even maybe ACFR for the anterior skull base for for resistant chronic sinusitis, or if there is any osteomyelitis. Skull-based cases are not very common and have very unusual presentation. Building the volume, this is very important. You should have marketing team, very good patient care, web presence. All the time you should be on the website and on the conference to show that you are doing this case, because these cases come only by a referral. The patients with pituitary will not come to you directly. Safety, again, experience, as I told you, is very important. You should increase your experience slowly. Training levels, level 1, 2, 3, 4. All of us know the levels of skull base, starting from level 1 sinus surgery, the level 2 CSF and pituitary, normal pituitary, extracellular approach for pituitary, the level 3. Level 4 is the intradural for craniopharyngioma, craniopharyngioma, like meningioma. This is level 4, and the last level is the vascular problem and the carotid dissection for any advanced case like malignant cases. Problems that we find, too much problems we are finding, and the most important thing is your mentality. You should prepare your mentality to be skull-based surgeon. You should be alert all the time. You will deal with very deadly cases. The patients, if you didn't manage his electrolyte disturbance very quickly, he might die. If you didn't know that, for example, the patient has some kind of insomnia after the surgery, even if there is no leak, you cannot, if you are not alert that this is meningitis, you cannot be skull-based surgeon. All these points means that you should be very good skull-based surgeon. And it's not only one or two cases a month, as I told you. You should prepare. You should have good number of cases to do this level of surgery. Business constraints is very important, because usually these cases are very, very expensive, honestly. And if you are not prepared, in your hospital, to get all the equipment, and if the patients cannot afford this level of surgery, it's also a very, very big problem. Other points we should be consider is the complex ethics in this one. In these cases, all the time, you should discuss with the patients about the points, about the pros and cons about every surgery, because this cases is full of complication, and you should discuss with the patients sometimes the possibility of death. So it's not easy at all. So understanding the possible complication, stressing on the informed consent, very, very important, the informed consent for these cases. You should prepare the very good informed consent for every case. Complex ethical issues, as I told you, long hours. Sometimes the surgery, maybe for meningioma, it takes maybe 5-6 hours. Stress related to the surgery, stress related to the patient, and arranging the subspecialty all the time. Cases are usually difficult and requires extensive multidisciplinary approach. Consent, as I told you, reasons for failure is too much, able to work as a team, and this is the most important. Inadequate training, taking the difficult cases in the beginning. You cannot go directly for a craniopharyngioma. You should start maybe the small microadenoma, something like this. You cannot go directly. Loss of patience. This is also very important. If you don't have the patience for a long time, you cannot be a skull-based surgeon, and many other failure causes. This is some of the cases we did it with my boss, Dr. Jana Kiram. Dr. Jana Kiram is coming all the time, every month, at least 2-3 days every month. We are doing many beautiful cases of skull base. This case of pituitary before and after surgery, complete cure of the patient get his vision completely. This is a case of chordoma, very big chordoma, as you see here, complete recovery. And this is Haddad flap. Patients get also the vision, and he's preparing himself to do cone beam, proton beam. This is very, very nice case of osteopetrosis, and I think my boss Jana Kiram is the only one who has this huge series of cases. This is a case of osteopetrosis. You can see here the optic nerve is like a pin in the sand, and here you can see here the 180 decompression of the patient in both sides, of course, one of the very, very, very complicated and difficult cases we see. Another case of GNA angiofibroma, another case of angiofibroma here, stage 4, came from Morocco. And this is a case for next visit, very, very interesting and rare case of third ventricle herniation, very rare, all the basis phenidyle is herniated to the bone, to the nasopharynx and oropharynx. Thank you so much for your attention. And now I'm sending the microphone to my big boss, Dr. Janak Hiram. Thank you so much.
Thank you, Dr. Saeed. Thank you for this swift presentation.
Thank you.
Please, Dr. Janak Hiram, the floor is yours.
Yeah. So a very good evening to all of you. It's a pleasure always when I address a conference or a webinar with Karl Storz. I have been working with Karl Storz for the past 35 years, 35 long years. It's a big journey, And I have been sort of, the KOL in the Asia Pacific, in Africa, and several parts of the world. And Karl Storz, I associate with them because, believe me, they are the best. So I want to be with the best, and I'm always with the best. Now, without much ado, I'm going to share my screen, and I'm going to my presentation. Mr. Tariq, please tell me if you're able to see the screen.
Perfectly well.
Okay,
Prof, you can go ahead. Yeah.
Now, you heard Professor Syed Al-Abash, who is my colleague, talking about skull base surgery. But the topic of today is basics of FES. I just wanted to present the skull base scenario first, because only if you aim at the star, you will reach the sky. So if you aim for something big like skull base surgery, then you can be a master of FES. That is why I wanted to show you that the spectrum of the level of endoscopic sinus surgery is now far beyond talking about the anterior ethmoidal artery or a concha bullosa or a middle meatal antrostum. That is why I made Professor Syed Al-Abash talk to you about how to become a skull base surgeon. So I'm a consultant in Medcare Sharjah, and I also am the director of Royal Pearl Group of Hospitals in many parts of India, which is the largest chain of ENT hospitals in India. Now, disclaimer, I am supposed to be an academic head of Karl Storz and Asia Pacific in Neurospine department. I have worked with them for at least 15 years now. Now, this is the center where we work in Medcare Sharjah, and also, you see Professor Syed Al-Abash and me with a happy patient. Now, let us go on to basics of sinus surgery, the surgical management. Now, I want to talk to you what Dr. Syed Al-Abash talked to you before. So I'm going to talk to you about a video. Let us see what is the limit which can be tested by sinus surgery, which is skull base surgery. So here, you don't talk about the uncinate, you don't talk about, the middle meatal antrostomy, you don't talk about anything except, the sphenoid sinus. The only part is the sphenoid sinus. So unless in endoscopic sinus surgery, you're conversant with the anatomy of the sphenoid sinus completely, you cannot go to the next level. So I urge all the youngsters to think about the next level, which is the sinus surgery, skull base surgery, rather than just talking about basics of sinus surgery. Okay, so I'm just going to show you some glimpses of how we do this surgery. I just want to show you some glimpses. Of course, this is how you see the sphenoid sinus. Optic nerve decompression on both sides. You can see I'm opening up the dura. There's the dura of the planum. You see how we open up the dura. That's the Kassam scissors by Karl Storz. So most of the instruments of the skull base as well as endoscopic sinus surgery are the high-end equipments. which are provided by stores. You can see that we're taking a biopsy of the meningioma. See how beautiful it looks. And this is what is called the extracapsular dissection. So so basically we go extracapsular, extra-arachnoid. Initially we debulk the tumor. See that we debulk the tumor, and then we go in for extracapsular dissection. See how beautifully we can do that. That's the anterior circulation. So here we are not talking about the anterior ethmoidal artery. We are talking about the anterior circulation. Please understand. So I am putting this because this is the limit you can achieve. And if you think of this, then sinus surgery becomes sort of so easy. This is the optic nerve, which is intracranial part of the optic nerve. Whereas in endoscopic sinus surgery, we keep talking about the Onodi cell, the optic nerve, which is there, prolapse in the Onodi cell. All that is just the primitive, stage of what is being done right here. And this can be achieved with a very, 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 good level of expertise. You see how we are rolling up the meningioma from the intradural compartment. See beautifully the anterior circulation and then the repair of the skull base defect. I just wanted to post this. See the post-op, how beautiful we take the nasoseptal flap. Well, why did I post that? Because in sinus surgery, this is the first step. You have to do at least 100 sinus surgeries before you achieve that level of expertise of a skull-based surgeon. A minimum of 100 advanced sinus surgeries. So how do we start with sinus surgery? What are the methods to achieve success in sinus surgery? It all depends upon a good case selection, a good surgical technique, a good post-operative follow-up, of course, by good training. And that's why we have IRCADs all over the world. And you can see here, imagine this. So if you have something like this, you have to always understand that any patient presenting with sinus disease, you should not take a scan immediately. You have to give maximal medical therapy. It's called MMT. And what is MMT? MMT is nothing but giving steroid sprays, sometimes oral steroid as well, along with nasal douching, along with culture-directed antibiotics for a minimum period of 8 weeks to 3 months. So you have to give it for 3 months and then only you take a scan. Never take a scan during an attack of cold or when the patient presents to you for the first time. So this is what is called maximal medical therapy. Now, the patient now has got qualified for surgery. So what is the surgical technique you will offer? Please understand the previous era of pulling, plucking, stripping is all gone now. If you use a Blakeslee forceps for pulling a mucosa from the sphenoid or from the maxilla, then you're outdated. Now, we don't do that. We use debriders. We use through-cutting forceps, punch forceps. All these are the latest eras in endoscopic sinus surgery. So now, what is the key objective to success? The key objective to success is standardization of a technique. So you learn a technique, you go to many centers, and then you perfect the technique by improvising it, and you standardize that technique. So you have already got the steps. These are the steps which I will do. For example, now we will start talking about some techniques which we do here. So what is MIST? MIST is minimally invasive sinus technique. So it's a functional concept and it is stepwise endoscopic intervention based on Missler-Klinger's functional concepts. So what happens is that it opens just the transition spaces between the maxillary sinus, anterior ethmoid, and the frontal recess. Now, what is the concept of MIST? We pack the nose. Nowadays, we don't even infiltrate. We medialize the middle turbinate and we do an unsphincterectomy. And you can now see that we always do a maxillary sinus opening, but not a very big middle Maryland prostomy. And we do a bulla up procedure to open up the frontal sinus and the posterior points. Now, let us go and see a video of how we do a mist. Okay, this is a video. You can see here, that's a concha bullosa. You can see that's a concha bullosa. And this is a video which was done by me around, I think 15 years back, or maybe even 17 years back. See how I'm now removing the bone inside the conchal cell. See that? This is what is called submucous dissection. That means you respect the mucosa. You respect the mucosa to the core. It's like the retinal surgery. It's like the corneal surgery. Now you see how gently you take your Nagashima backbiting forceps. You just punch the uncinate, take a debrider blade, and then take an uncinotomy knife. This is called the uncinotomy knife. And we do what is called the uncinate flap. You can see that very beautifully. I take the horizontal part of the uncinate and gently we open up the middle meatal prostrum. You can see that how beautifully the ostium is opened, and then gently take off only the medial mucosa and take the bone. So these are all layer by layer dissections. So it is very important that you respect the mucosa. This is very, very, very important. Many people feel that just plucking, pulling is called fess. No, it is not fess. That is a mess, not a fess. So you see how we are taking, see that's the Aganasi. And you see how we are doing what is called the submucous dissection of the Aganasi. I'm using a 70-degree telescope. And then you see how we are not going to disturb that mucosa. And you can see that frontal beautifully here. And this is how gentle you should be to the mucosa. That is the bulla. So you open the bulla very, very softly, and that's the end of the mist. So what I mean to say here, insisting again and again that you have to be very, very, very gentle to the mucosa. Let us go on to some basic cases which we face in our day-to-day practice. This is an antroconal polyp. So you all know that antroconal polyp, how do we operate? So if this is an antroconal polyp, the first thing you do in an antroconal polyp is you use 1 in 1,000 adrenaline, 1 in 1,000 adrenaline, and you squeeze the polyp by mechanical and chemical action. You see what I do? I keep packing so that the fluid is taken off. Now you can see how beautifully, and then you chop off the nasal and the choanal part. So you see how I'm doing that? It is the cutting off the nasal and the choanal part. And once you do that, the choanal banking effect is gone. So once you do that, I will gently remove that antroconal, the choanal part and the nasal part of the polyp through the mouth. This is what I'm doing right now. See, once you do that, then you do the middle meatal antrostomy. You can see here. And then with the debrider, you just take it off. The upper part of the uncinate is taken off. And then this is the middle meatal antrostomy. Very gently take that mucosa and then take off the horizontal part of the uncinate. Look for the attachment. You look for the, see. This is a 45-degree telescopic view of the attachment of the antroconal polyp. You see how beautifully, gently and slowly remove the attachment. Unless you remove the attachment, believe me, you will have a recurrence in an antroconal polyp. So that's the end of the surgery. You see how, and you have to remove a little bit of normal mucosa all around. So this is the end of the surgery. You see how no bone should be exposed. No bone should be exposed. These are all dictums of sinus surgery. Now let us go to ethmoidal polyp. How do we do? If the patient is a hypertensive, I am seeing that, we operate in various countries with a lot of, bleeding and things like that. But yes, you can do a good sinus surgery. This was operated by me around 17 years back. See how the quality of that picture was 17 years back when I operated. The CT scan showed bilateral polyposis involving all the sinuses. So I'm going to do a full house fess. Now let us see this endoscopic sinus surgery was planned. How do we plan an endoscopic sinus surgery? Let us see. Patient had a concha on the right side and a dehiscent carotid artery on the left side. So you see how I'm doing. Always when you do concha bullosa surgery, go from below upwards. Don't go from above downwards. Go from below up. These are all basic basics in endoscopic sinus surgery. Basics. So go from below upwards, because if you pull it from above downwards, you will destabilize the sagittal attachment of the uncinate of the middle turbinate. Now that's a through biting. You see how I'm using the through biting, and then you can use the debrider, of course, and you can see that now we have got the out, the concha bullosa out. There were some polyps inside the conchal cell, and we are getting that out, the polyposis, the polyps, multiple polyps out, and you can in fact eat off the bone of the lateral lamella of the concha bullosa. And once we do that, you can see very nicely the conchal cell has been opened up. So next, what we do, we open up the infundibulum. How do we open up what is the infundibulum? Infundibulum is the deepest part of the middle meatus. So osteometal complex, of course. So you can see here that is the uncinate process, which is leafy and polypoidal. We are now, trimming that uncinate process. And once we trim the uncinate process, you can see that uncinate process becomes, it's a medially rotated uncinate process. And what we are doing now is to define the bulla as well. And that's the bulla. Now you see how beautiful. Now, to take off a medially rotated uncinate process, my technique is I first use a sickle knife for the medial part of the uncinate. See that? That's a medially rotated part of the uncinate. I use a sickle knife. And then I move that part of the uncinate medially. See that? So basically, I don't use a sickle knife for a normal uncinate. Only for a medialized uncinate, I use a sickle knife. I use a through biting forceps. That's a through biting forceps. And you can see that now that's a medially rotated part of the uncinate. Beautifully seen here. And I remove that part of the, That's the medially rotated part of the uncinate. Okay, right. Now what I will do, okay, now I'm now trying to, so now I follow the regular steps, that is the uncinatomy knife. And you can see here that we are opening up the natural ostium of the maxillary sinus. I've seen many young surgeons, what they do is they open up a new ostium. Never do that. Never do an axillary ostium opening, because you will have a subculus phenomenon. So you're having a debrider and you're trying to open up. See, at no point I've used a Blakeslee forceps to pull. You should understand that. So pulling, never do in basic FES. In basic FES, never do a pulling. So then we give a good wash. You can give a good wash. And I always combine it with a little steroid also. The washes will contain a little bit of steroids. And that is actually the middle meatal antrostomy which has been done. It's a wide middle meatal antrostomy. In polyposis, it's better to do a type 2 antrostomy. And then what we do, you can either practice the centripetal approach of, Filippo. Professor Filippo has, from Brazil, he has actually propagated the centripetal approach. I follow the centrifugal approach. You can see here, I'm going through the bulla. This is what is called the lamellar concept of Stamberger. Lamellar concept of Professor Stamberger. We dedicate all these presentations to Professor Stamberger. We remember him always, and because he has given this to the world. So you can see here, that is the lamella of the bulla. And you can see we are removing all that polyp along with the medial wall of the bulla. This is the medial wall of the bulla. And once we do that, you can see that's the lamella. So this is the uncinate lamella. This is the bullar lamella. So this is what is called lamellar concept of FES. Lamellar concept of FES means keep the lamellas intact. So this is the lamella here. So the uncinate lamella, the bullar lamella. This is the basal lamella now. This is the third lamella. Now what we do for the basal lamella is there are two kinds of dissection. One is called sharp dissection. Second is called blunt dissection. So here I am doing what is called the blunt dissection of the basal lamella and the posterior ethmoid. You see, I'm just introducing a little gauze piece soaked in adrenaline, and I'm just breaking off all the small lamellae in the ethmoids. See that, how gently we are trying to break off all these lamellae in the ethmoids. So once we do that, This is all basic sinus surgery. Every day you're going to see these cases. So that is why I'm presenting it. So if you want to be a good skull-based surgeon, believe me, you have to do. So this is the third lamella. You see, that's the third lamella, which is the basal lamellar lamella. So that's a lamella of the basal lamella. So the third lamella is the basal lamella of the middle turbinate. This is the middle turbinate. The basal lamella of the middle turbinate is the third lamella. The fourth lamella is the basal lamella of the superior turbinate. This is the superior turbinate here, and you have a lamella there. So there are 5 lamellae. First, uncellate lamella. Second is bulla lamella. Third is basal lamella of the middle turbinate. Fourth is basal lamella of the superior. That's the basal lamella of the superior turbinate. And fifth is the sphenoid sinus. So unless you see all the 5, this is 3, this is 4. And now you can see that's the posterior part. Can you see that, Soumya? Very beautifully. This is called lamellar concept, which was propagated by Professor Heinz Stamberger. So remember this very well. So you can see very beautifully that I'm just defining the lamella there with a debrider, no pulling at all. If you see, the whole fess is done with just one instrument, and that's the debrider. So you see here, that is the skull base there. Now we are creating what is called the superior meatal window. This is called the superior meatal window. So your debrider is directed away from the septum. Very important, your debrider is directed away from the septum. Your movement is from above, downwards, below, upwards, like that. See the movement along the superior turbinate, and you should not resect the complete superior turbinate. Only the lower third of the superior turbinate can be resected because you have olfactory function of the superior turbinate. So what you're doing now is to open the natural ostium of the sphenoid sinus. So there are 3 methods of opening the sphenoid sinus. One is like, the medial approach. You see the Onodi cell. See, that is a beautiful view of the optic. This is the carotid, this is the sphenoid sinus, and that's the Onodi cell. See how beautiful it looks. This is the sphenoid, that's the Onodi cell with the optic nerve. See, that's called the Parsons ridge here. This is the Parsons ridge, and that's the skull base. Now, you can see inside the sphenoid sinus, this is the interior of the sphenoid sinus, that's the cellar floor. You can see that's the cellar floor. And you can see here that I am now breaking the Parsons ridge. What is this ridge which separates the Onodi from the sphenoid sinus? Called Parsons ridge. So you can do it with either the punch forceps or the debrider, but be careful, don't introduce the debrider inside because you might hit the carotid artery. So you should stay along the anterior wall of the sphenoid sinus. It's very important that you stay. See the fess. There is no stalactites or stalagmites. See, the lamellae are seen beautifully. See, that's the sella. This is the clivus, the carotid artery, the optic nerve. This is the Parsons ridge released. So this is the 5th lamella of the sphenoid sinus. And you can see here that this is the paraclival carotid sella, and you can see how beautiful it looks. This is the kind of work. That's a median nerve. That's a V2. This is a lateral recess. All these beautifully seen. You can see that all are very nicely seen. And now I'm going for the frontal sinus. You can see here. This is the final. I usually do the frontal sinus. And how do we do it? We always go hug the nasofrontal beak. So you can see here, I use a J-curate or a ball probe. These are the best instruments to do frontal recess work. See here, I always stay close to the nasofrontal beak. Here, I'm not trying to strip the mucosa. If I put a sort of a debrider and just screw it, then I'll get a circumferential stenosis, and that will lead to a stenosis of the frontal recess. So what I'm doing now is gently taking off the bone. That is the frontal, very clearly seen. Now again, I'm using the blunt technique, not the. So these are all very easy techniques. Many people are scared of the frontal. Don't be scared. You should do a blunt technique if you're scared. So you can see here, this is the frontal. The gauze piece is very beautifully seen inside. And I'm just removing the gauze piece. See how beautiful the frontal. Wow, superb. Now you can see the frontal recess and the polyp just prolapsing from the frontal recess. And now I will use a debrider And I'm going to open up the frontal recess very beautifully. See that? See how nicely. And you have to always take off the lip which separates the frontal ostium from the anterior fovea. Now, I'm going to show you this very beautiful thing. Whenever you open the frontal, just check this. See, the anterior border of the frontal is the nasofrontal beak, number one. Number two, the medial border of the frontal recess is the middle turbinate. The lateral border is the lamina papyracea, and the posterior border is the anterior modern artery. So from here to here is the frontal recess, not from here to here. So it is from here to here. Can you see my cursor, Mr. Tarek? Can you see my cursor?
Yeah. It's showing very well. Yeah.
So from the nasofrontal beak. So again, I repeat for the juniors who are doing basic endoscopic sinus surgery, the boundaries of the frontal recess: anteriorly nasofrontal beak, posteriorly anterior ethmoidal artery, medially middle turbinate, laterally lamina papyracea. Unless you see these four boundaries, you have not opened the frontal recess completely. So this is the frontal, the anterior fovea, this is the posterior fovea. So this is the anterior ethmoidal artery, which goes from posterior to anterior, lateral to medial, posterior to anterior. So you can see that this is the final view of the skull base. So you can see frontal, the anterior fovea, that's the anterior ethmoidal artery, the posterior fovea, and of course you have the Onodi cell and the plenum. See, this is the kind of surgery I expect when a basic person does an endoscopic sinus surgical work. See the kind of cavity you have. Such a beautiful looking cavity. There is no, a lot of, bones hanging here and there. It should look beautiful. It should look like, because then only there will be a good mucociliary clearance. The mucociliary clearance will be there only when you have this kind of cavity. If you have bone, raw bone exposed here and there hanging, then what will happen is you will have osteitis and you will have reinfection. You see the other side sphenoid sinus. How the dehiscent carotid is seen. See the carotid artery. Why did I say you should not put the debrider inside? See that other side sphenoid sinus, you can see the carotid pulsating. Oh my God, if you put the debrider inside, imagine what will happen. The patient will die on the table. So you should know that don't use the debrider right inside the sphenoid sinus. See this. See the mucus clearance. See that RBC is being transported. See beautifully seen the mucus transport. Wonderful. See the RBC is moving here. So all that is for you to enjoy, as well as be careful about not doing harm to the patient. Now we come across in basic sinus surgery work a lot of fungal sinusitis. Now we have various classifications. I'm not going to deal with it. I'm going to show you one beautiful case of sphenoid sinus fungal ball. Please understand, when you use the term fungal ball, it means there is a fungus only in one sinus. So for example, you can say sphenoid fungal ball, or you can say maxillary fungal ball. So the anatomy of the structures related to sphenoid sinus can be seen by this video. You're going to see how. You can see here. This is actually the presentation of the patient. You see the carotid here. This was actually fungal material. You can see that's the MRI showing sphenoid sinus involvement. You see, once I open up, this is how it looks. So these are all very basic endoscopic sinus surgeries which you're going to see in your day-to-day practice. So unless you do these cases, you cannot progress on to becoming a skull-based surgeon. Now here, what I'm trying to do is I'm trying to take off all that fungal ball. This is not anything else other than a fungal ball. It's just involving one sinus. There is no mucin. So to call it allergic fungal sinusitis, you should have allergic mucin. You should have, you should have chitin material. So this is just a fungal ball involving the sphenoid sinus. Of course, you might get confused a little that it could be allergic fungal sinusitis. Yes, it can be, but the biopsy was not that way. but it's okay. It's fungus. And in this case, we didn't give any antifungals. You can see here how the fungus is sitting right inside the clivus. So here you can see that's the intersphenoidal septum, which has been pushed to the right side. And you can see here that you should remove every bit of this fungus. Please understand, if you don't remove this fungus, what happens? The problem is the mucociliary transport is affected. So what happens is that it'll create a polyp. So presence of the fungus, it will lead to a polyp. Okay, so I'm now going to just forward it a little bit due to lack of time. That's the erosion of the bone of the same case. That's the clivus, the paraclival carotid. This is the sella here. And you can see here, this is the dura of the sphenoid sinus, the intersphenoidal septum. I'm opening up this is the right side. You can see how the cavernous sinus. See beautifully. You can see never pull at an intersphenoidal septum. Very important. Why? Because it can get attached to the carotid artery. So always use a through biting. See how I'm using a through biting forceps. Very, very important, my dear friends. And see how I'm doing a submucous dissection of that intersphenoidal septum. See how beautifully we are able to do it. So it's like a piece of art. It's a piece of art. So you should always think that surgery should be artistic. Very, very important. Now, once you do that, I'm taking a through biting and cutting it inferiorly as well. See all these, and then finally, I'm getting that, and we'll see the view. Now, see the cavernous sinus. See the cavernous sinus of the lateral wall. This is actually the carotid artery. Carotid artery. That's the sella. And you see the anatomy. You should see the anatomy of the sphenoid sinus. This is the beautifully the cavernous sinus in blue. And you can see that I'm using a probe to, that's the course of the carotid. The cavernous carotid is here. And then let us see here. So this is actually the interior of the anatomy. Now let us move on to AFRS. This is another very common condition. Even today morning we did a live. You can see here. You can see how this fungal polyposis can actually involve. This is called the whiteout scan. It's called the whiteout scan. You can see here. And you can see how we are actually removing all the polyp. Today morning you saw the case live. I'm sure most of you would have seen it. Of course, I'm just showing you that this is a case of frontal sinus. You see how the frontal sinus has been opened. Always use a 70-degree telescope for the frontal sinus. Many people don't even have a 70-degree telescope and they operate on endoscopy. See the anterethmoidal artery. Today morning also we did it. This was done around 18, 19 years before. See that. The anterethmoidal artery is hanging in the middle. See that. Now, this is how I expect you to do an endoscopic sinus surgery as a basic person. Now, I just want to show you this because very rare video. So even though it's a very old video, just want to show you what is nasal cholesteatoma. This is what is called nasal cholesteatoma. So it's otherwise called rhinitis caseosa. See how it's like a curd butter. So it's very rare to see such a case. So that's why, even though it's an old video, I love to, present this video. I don't think many of you would have seen this kind of nasal cholesteatoma. And this is the nasal cholesteatoma involving the maxillary sinus. The external ear cholesteatoma is called keratosis obturans. So the nasal cholesteatoma is called rhinitis caseosa. So this is what I wanted to present. Now, coming to the last, how will you manage sinus surgery post-operatively? So the goals of post-operative care is to reduce inflammation, reduce infection, promote ciliary function, and prevent complications. So these are the 4 goals of post-operative care. So what are the stages of healing? You should know what are the stages. If the patient comes in the first week, what will you expect? You will expect edema and crusting. So you have to just remove the crust alone. Don't go and screw the nose. The best thing is just ask him to douche nicely. So what do you ask him to douche? You can use saline douches, or you can add a little bit of sodium bicarbonate. So you make it alkaline, the pH making it alkaline. The second week, what do you expect? So you expect soft tissue exudates. This is the problem. The problem week starts from the 7th day to the 3rd week. Why? This soft tissue exudate, it has a lot of fibrin, and what happens is finally it leads to Seineke formation. So this is the time when you have to take off all the soft exudates. So your aggressive suctioning or follow-up should be between the 7th day and the 3rd week. If you do a good post-operative follow-up, then you can avoid a Seineke and your cavity will be stabilized. So look at this. Look at my cavity. This is post-operative. This is stage 1. This is stage 2. This is stage 3, a stage 4, and a stage 5. These are all healing stages. So I keep recording all my healing stages. See the 1OD cell here. See the 1OD cell here. So these are all the frontal sinus, how the anterior caudal artery heal. So here we are. If you look at the stages on videos, see that if you look at the stage, you should be able to say what I have done. Anybody can say this is an axillary flap. So I've done an axillary flap. If you see this, you have to say I've done an axillary flap. These are the kind of observations you should have when you see a postoperative cavity. Now you can see that's the stage of edema. That means it is between the 1st week and the 3rd or the 4th week. So what you can do is gently push. See, this is a very dangerous thing. You have to give aggressive steroid sprays, and also sometimes I also give oral steroids. If you don't give oral steroids, sometimes the patient can have a persistent, edema. And what you can do is gently, press that polyp. So that what happens is the histamine comes out. So this is some sinuses are nicely epithelialized, the ethmoid alone. That's because of the Bernoulli effect. That's because of the airflow. Now you see the same case, when you follow up, the patient heals well. So this is another case where you keep gel foam. Many people keep gel foam, never keep gel foam. If you keep gel foam in the cavity, problem is you can have Seineke. See, you can have Seineke, but this is the kind of cavity you expect when you do endoscopic sinus surgery. So now we have what is called POSICEF. Professor Syed Al-Abash is using a lot of POSICEF, and I am not able to get it in India. I've been begging him, please, sir, I would like to have POSICEF. And this time, actually, he ordered, but the person didn't come. So see, this is a kind of cavity you want to expect. Now, let us see what is called Kupffer-Berg classification. So I have another 2 minutes only. After that, Mr. Tariq has asked me to stop. So you can see here, this is a stage 0 where no mucosal edema. Stage 1 is mucosal edema. Stage 2 is polypodal edema. This all, if it happens after the stage of the stage 2, after stage 2. So see here, you cannot, if it is between 3rd week, you don't call it Kupffer-Berg 3 or Kupffer-Berg 4. So this is very important. You should know when to call it. And you see, this is not a great idea to have Seineke inside. You see, that's a Seineke. What will happen in long run is this middle turbinate will be pulled laterally. So what I usually do is to cut off that Seineke. I cut off that Seineke, I keep a little spacer. So these are all post-operative cavity managed. See what I do. I cut off that Seineke. Why? Because that middle turbinate on later, after 3-4 months will pull and it will obstruct the middle meatus. So now you can see, there are some cases you don't expect this. 1 month before you operated, the 4 weeks already over, and you see this, what happens. So these are cases where you have to give, oral steroids. So give oral steroids, you see that kind of crusting, and, this is not a very great result. And after 1 month, then you have to immediately start. You should become very aggressive in your post-operative follow-up. In fact, Professor Syed Al-Abash has got a lot of experience on use of biologics. So I think he can talk better than me. Now, we always advocate saline nasal douching. I have 1 minute, 22 seconds more. So we always have a mixture of sodium chloride with sodium bicarbonate. So why? Because sodium chloride causes osmotic diuresis and sodium bicarbonate increases ciliary motility. So you can see here, so these are the office visits I usually advise, and corticosteroid sprays always, and then topical nasal steroids. The best would be fluticasone furoate. That is the best. Of course, we add mupirocin in some cases of MRSA. If it's MRSA, we go in for mupirocin, and tobramycin also has been advocated. And of course, these are all systemic steroid therapies. Now, I think I have to stop because what are the recent advances? I just want to tell you about drug-eluting stents. Of course, again, Dr. Syed has got more experience. In fact, he taught me how to do it. I did one case in Dubai under his guidance, Propel stent, and he has done a lot more. So, and about the biologics and the biofilms, and this is all just, you have to go through these, fantastic videos of biofilms and how you treat it with Manuka honey. Manuka honey is a very good product where it releases methyl glyoxal, low pH, and it has got an antimicrobial activity. And you should have an NGO concentration greater than 0.53 milligram per ml. So what's the conclusion? What's the conclusion? Conclusion is functional endoscopic sinus surgery has over the years become a more aggressive interventional procedure. This is very sorry state of affairs. I'm seeing cut turbinates. I'm seeing cut, everything is being cut. Please don't do that. Be as conservative as possible. You have to be functional, not aggressive. There are several variations in FES with no standardization. So try to standardize your technique. Give the best to the patient. Everybody does FES. It's the finesse, it's a finesse which differentiates between the surgeons. So your FES should be like this. You are the surgeon, that is the nose, and you should absolutely be in synchrony with the nose. Don't damage the nose. Believe me, if you damage the nose, you will never get it back. And I thank Karl Storz and Professor Syed Al-Abash for this wonderful evening with me. Thank you very much from India, and thank you from Sharjah.
Professor Janakiram, I mean, I don't know what to say. I really thank you so much. And you made me regret telling you that we need to stop at this hour, because I personally can listen to you going for hours and hours. What you presented was really great. I mean, going step by step, detailing all the FES surgery and how we move forward from one lamina to the second, and the cleanliness of your surgeries is like was bringing joy to me, to be honest. So thank you so much for this beautiful presentation. Dr. Saeed, also thank you for your presentation. It was really nice giving the tips and tricks of moving from like the regular sinus surgery to skull-based surgery. I have to tell you, Dr. Jana, one thing, and to tell all the audience that this is the first eMasterclass webinar of a series that we are planning. Please, everyone listening, everyone with us in this webinar, stay tuned for what's upcoming and what's coming next. We're gonna be sharing with you the links, of course, for the upcoming planned webinars. All right. Now we have few questions. I'd like to address them, coming from, of course, different doctors. So we have a question, first question coming from a young otolaryngologist who is very passionate of nasal sinus and skull-based surgeries. So what advices could you give me to excel in these fields? Wow, this is a very general, big question. Maybe just try to make FES, not mess, right? So
No, I want to advise, if you want to become an expert, there are two things you have to follow. Number one, cadaver dissections. And when you do the cadaver dissection, treat the cadaver like your patient. Because I see that most of them, when they do the cadaver dissection, they just pluck, pull, and they just want to open up the maxilla. No, you have to treat it so gently and think that that is your surgery. So if you keep doing your cadaver dissections, believe me, you will be a master. This is the only trick.
Perfect. So another question or comment, if I'm not mistaken, he's saying consistent landmark of anterior ethmoidal artery is basal lamella or frontal infundibulum. So it's a question, I guess.
Basal lamella or what?
Frontal infundibulum.
Oh, okay. So basically, anterior ethmoidal artery, the best landmark would be the basal lamella. So the anterior not the basal lamella, the anterior attachment of the bulla. Anterior attachment of the bulla, the superior, anterosuperior attachment of the bulla, its anterior ethmoidal artery is always behind it. It's always behind it. So if you're really worried about anterior ethmoidal artery injury, do a bulla up procedure. So do the frontal sinus, and then if you open up the upper part of the bulla, you will find the anterior ethmoidal artery. Okay, so that's the best line.
Perfect. What is the concentration of steroid for nasal wash? I mean, this question also maybe for both of you. So, yeah.
Dr. Syed, you want to take that?
Yeah, but like there is no standard concentration, but usually like within 250 ml, you can maybe use like the 1 ml or 2 ml of 0.5 of Palmicort or budesonide or whatever. There is no standard. Some people, they are using the full concentration directly. Of course, it depends on the severity of the problem, but usually there is no standard. But most of the doctors, they are using 1 or 2 ampoules of Palmicort 0.5 in like 250 ml of normal saline, 2 or 3 times daily according to the situation, of course.
Perfect.
Yeah.
Okay, another question. Does the intact bulla technique work in case we have large bulla and suprabular cells present?
Dr. Syed, you want to take that?
No, please, boss, please.
Okay, so the intact bulla technique definitely works, but it doesn't work if there is a posterior group of cells. That is, there are 3 group of cells which are called posterior group, according to Frederick Kuhn's classification. One is the frontal bular cell, the supraorbital cell, and the suprabular cell. In these 3 cells, don't try to do a intact bulla technique. It's not going to be very great because there is a very less space for you to operate. So it's better to do a bulla down.
Okay, perfect. Is the anterior ethmoidal artery always covered by bulla or any exceptions?
Always covered by the bulla. See, basically, if you have a suprabular recess, then you may not have that, the vertical attachment. So sometimes, you open up the frontal, you may not have the superior attachment of the bulla, then you might have the anterior ethmoidal artery behind. It depends on the pneumatization of the suprabular recess.
Perfect.
Read your scan. And if you have a supraorbital cell, then that is where you should be careful because the anterior ethmoidal artery will be dehiscent. The anterior ethmoidal artery will be dehiscent when you have a supraorbital pneumatization.
Perfect. We have a question regarding the angle of and size of the shaver blades for frontal sinus. So what's the angle that you recommend? What's the size as well?
I will mention this one. Usually for the frontal sinus, we prefer to use the 70-degree one. This is like 60 degree.
Perfect. Yeah.
Usually, of course, it depends from like company to company, but usually we are using the 60-degree.
Perfect. How to deal with extensive inflammation post-FES in eosinophilic chronic rhinosinusitis with polyposis and asthma?
Yes, just I'm sorry, boss. Okay, I have like a very aggressive management for cases like this. For every cases of chronic rhinosinusitis, I'm doing full blood count, IgE, take a biopsy from the polyps or the mucosa and define how much severity. And all the time, for me at least all the time, I'm using the biology for every case after the surgery, in addition to the immunotherapy. I'm doing all this because I know those people might recur, and I don't want my patient to recur anymore.
Professor Syed, can you elaborate on the biologics which you use?
Yeah, see, biology is now very, very big like concept now.
Topic.
And of course, every day you can see new biology. Usually, like the first you can say generation is the omalizumab, the Xolair, which is doing good, of course, but of course not like the second generation, which is like Mipo and Dupi and Gisli and all of them. What is recommended from the organization now, the Xolair, omalizumab, and the Nucala, mepolizumab, and the Dupixent. Those are the others. They don't have too much like evidence for that until now. but slowly, many of them are coming like in the market, and of course, all of them working for the same problems like asthma and atopic dermatitis, food allergy. All of this can work with this one. Personally, I'm using for every patient after the surgery because I want to give the patient the best. Of course, not easy to do that, but this is my opinion. Too much discussion about this one, and of course, biology is making our life very happy, and it also covers like the incomplete surgery, which is of course not good for in general, but this is what happened usually. So even the doctor is not doing very good surgery, and he gave the patients after that biology, okay, the patients surely will get very good improvement, and will say, this is fantastic surgery. But after doing the endoscopy, after stopping the biology, you will find that this is not good surgery.
Perfect. Thank you so much, Dr. Said, for this answer. How to identify the ascending pharyngeal artery while performing wide extended sphenoidotomy?
Ascending pharyngeal artery?
Yeah.
You don't have to even think about it. Where is it nearby? There's nothing
Okay.
near.
So, okay, I think the answer is there. What, in your opinion, is the best tip or trick to or application to prevent synechia?
The best is a good douching protocol, followed by a very nice post-operative follow-up protocol, along with a good bulgarization or a stitching of the middle turbinate, and good use of spacers like Posicef, which are coming up in a big way right now. So use spacers, suture turbinates, good follow-up. These are the way to prevent synechia.
Perfect. What's the best way to deal with adjacent anterior ethmoidal artery?
What?
The best way to deal with an adjacent anterior ethmoidal artery. I think
Adhesive.
adjacent. Yeah.
The best way, if you're scared about it, don't even go near it. So that's the best way. If you
Yeah, just one thing. Anterior ethmoid artery is our friend. It's not our enemy. This is the point, Yani. Okay, don't worry about it. When I see it, okay, I feel okay, everything is okay. I read the skull base, everything okay. So it's no need to worry about it. In case like it bleed for any reason, you can just easily bipolar it, and that's it.
Only thing is, don't try to go inside the eye and catch it. This is something we should not do. And if it retracts into the eye gets swollen, and then you look for the tonicity. The eye starts swelling very fast, and then you press and see. The eye becomes very firm. And what happens immediately, what you should do when you're on the operation table, then try to do a medial orbitotomy. Today also we demonstrated it. Just remove the lamina papyracea, make 2 incisions. That is enough. Then if you are seeing it in the ward, do a lateral cantholysis. That's it.
Lateral canthotomy, yeah, perfect. So, do you recommend putting nasal gel foam in the middle meatus to avoid adhesions?
This is exactly what I told you. Don't use gel foam.
Don't use gel foam. Okay. I'm just reading through the questions, Dr. Janaki Ram. So
Yeah. You're doing great, Professor Tareq.
Thank you. Okay, I have a very nice question, to be honest, and this is I think this is a case that can be found anywhere. So besides using a shaver or a motor debrider, what advice can you give to low resource settings where you do not have the powered instruments? We can still rely on like normal instruments. So can you give some advice, please?
If you don't have powered instrument, then go with Karl Storz through cut forceps. So get the following. Number 1, get a straight through cut, get an upturn through cut, get a punch forceps, a good upturn punch, a lower biting punch, and a mushroom. And of course, a giraffe. So these 5 should be there if you don't have a shaver. If you pluck with a Blackesley, it is not fess, it is mess. Please understand that.
Perfect. In CSF rhinorrhea, when do you use fluorescein? All of the cases, are you using fluorescein in this case, or? What's your
Now,
recommendation?
fluorescein is used only in selective cases
Mhm.
where the patient doesn't have a leak during the examination, or the scan shows sort of a defect, and you have multiple defects. So post-traumatic defects, these are where we use intrathecal fluorescein. And what is to be taken care of is that you should get a separate consent for it, because fluorescein is FDA banned. So if you want, the patient can have an epilepsy. Be very careful, use it, make the patient in the Trendelenburg position for 45 minutes, and then use a Karl Storz, the filter, the green filter. You have a green filter attachment, put it, and then you will see the green birefringence.
Perfect. To prevent lateralization of middle turbinate, can we do partial middle turbinectomy?
No, that's not a great idea. You have to suture the middle turbinate or do a bulgarization. Don't resect the middle turbinate. It'll be a problem. Don't do that.
Perfect. Okay. What are the pre-op and post-op commandments you do routinely on fast surgeries? I think that's also a big question, but if we can go like with it very, very tightly.
I think we have released a book on 15 commandments. It's there on the YouTube. You can see the Karl Storz, the silver book which I've written. You can see that. I think these are all basic commandments, like how to hold the scope, how to position the patient, how to use the angle telescopes and things like that. And the post-operative, I've already dealt with in very great detail, how to follow up, how to follow it every week. And I think that's it.
Perfect. Is there
I
any
think,
rule?
Mr. Tarek, we should do a lot more, series of webinars on various aspects of sinus surgery. And
100%. This is the plan, and anyway, I'm gonna be in touch very soon to agree on the second one coming, so we can announce it also. I
we
cannot
will
announce it
split
now.
it like this. We'll have frontal sinus surgery separately, because
Okay.
that will be a very big topic to deal with. We'll have
Perfect.
sphenoid sinus. We can have beautiful, different kinds of topics of interest to many people. Today we had a very large crowd, very large crowd.
It's beautiful. Honestly, it's beautiful. I mean, all were attending and over and above and beyond. So really, I'm so happy with everyone here, and of course, so happy being with you in this webinar. So yeah. Okay, I have some more questions. Are you okay to take some more questions, Dr. Janakiram or Dr. Saeed?
I think I'm late for my surgery. I think
Yeah.
we are on time now. It's okay. I think we will call it a day. We'll take the questions the next time.
Yeah.
And you
Perfect.
can pass it on to me, maybe, or on email. I can answer it.
Maybe we can do that as well. So I think it's all recorded here in the question and answer section. Again, thank you so much. Always a pleasure. Thank you, Dr. Saeed, also for your availability and presentation. Nice presentation with us. Thank you, everyone, for your attentive listening. I'm sure everybody was like all ears and eyes wide open during the webinar. So
just one thing,
thank you so much. Yeah.
That's just one thing. Like I am can tell everyone like that we are doing a surgery of skull-based surgery every month. Janakiram is coming to us every month. We are doing a lot of skull-based, like all aspects, like ventral and lateral skull-based. And if anyone maybe want to come, like it's our pleasure, he can come, and we are of course welcoming everyone wants to come to see us anytime. No, Dubai is now a hub. It's very easy to come here. Like although India and Trichy is very precious, but going there, I tried myself. It's not easy, honestly. If you are coming from some places, you should take the vaccine of polio. This is very difficult.
No, you can arrange for some fellows to visit Sharjah, where we operate on skull-based surgeries, so that they can come and watch us do the surgery.
Yes. Yes, that's it.
Perfect. Perfect. All right.
Thank
Have
you
a
very
good
much.
evening, everyone.
Thank you.
Bye. Cheers.
Bye bye. All the best. Cheers. Cheers.
Thank you.
Bye.